Introducing Dr. Sipe today. Dr. Walter Sipe earned his medical degree from UCSF and he completed a residency in pediatrics at Boston Children's Hospital and Boston Medical Center. And then at UCSF, he completed both a fellowship in pediatric gastroenterology and also a residency in psychiatry. His unique expertise in both disciplines enables him to provide holistic care to children with conditions that affect both the gut and the brain, such as chronic pain, as well as for children with dysautonomia. In addition, he provides counseling and support for effectively managing and coping with complex medical issues. I know that I find it challenging to care for our patients with GI conditions that cause chronic pain, and I am very excited today to learn from Dr. Sipe how to address the suffering of our patients effectively in his talk on approach to disorders of gut-brain interactions.
Thanks so much, Lisa. I'm really happy to be back here. So as you said, I'm sort of first trained as a gastroenterologist, but as you can see from my office in the background, it's what you might imagine a shrink's office to look like with those comfy psychotherapy chairs. And my intent today is really to focus on what we might say is stance rather than technique. How do we even just create a context in which we can create an alliance and to help our patients? So for disclosures, I have been an advisor to Mahana Therapeutics, who developed a FDA-approved prescription digital app for IBS. I won't be mentioning that in any more detail. And I may touch on off-label use of mirtazapine and beta blockers. So what are really some of the essentials? I think you may see me kind of going back and forth. We've historically referred to kind of the things like IBS, functional dyspepsia, chronic abdominal pain as functional GI disorders. And I think they're probably more effectively conceived of as disorders of gut-brain interaction. I think the Rome-4 work group has started to make that shift. And I think it's a bit of semantics, but I think language is important because I think functional tends to sort of activate this notion of psychogenic or non-organic, which I think is one of the first problems we have to address in stance. And I think just using disorders of gut-brain interactions, DGBIs, tends to then orient both providers and patients to this notion of what we think of as functional GI disorders really are a holistic interaction between peripheral and central functions. I think it's also really important as gastroenterologists to be able to articulate and modify this interaction from both ends, right? So nothing I'm saying you shouldn't necessarily expect to be psychiatrists, but central functions that impact GI motility, GI sensation, I would argue are the purview of gastroenterologists. Many psychotherapists, many psychiatrists really don't have the physiology or the grounding to be able to explain and articulate GI sensation physiology adequately. And so oftentimes mental health providers are in the situation if somebody has increasing symptoms to just say, well, talk to your physician or go to the emergency room, which kind of tends to drive a vicious circle. Another, I think, important piece as we think about the stance is that the greater part of distress in DGBIs from both patients and families, if you're working with young people, is often from the unworkable attempts to avoid unwanted or uncomfortable experiences versus any particular set of symptoms, right? I'll talk about this in more detail. Now, the symptoms can obviously be distressing, right? But if you have somebody, for example, who isn't going out, isn't socializing because they won't go anywhere where they don't exactly know where a toilet is, it's that fear of being caught out and that anxiety that's actually causing much more suffering and disability than bowel urgency that might arise, unexpectedly. And so being able to start to create a frame where we can talk about not just symptoms, but how people are dealing with their symptoms so that they can live in a more values consistent way is an enormous, enormous benefit to our patients. And it gives you as clinicians a whole nother avenue to intervene on rather than just trying to track symptoms per se. Right. And in other words, this is a little equation, but that suffering often equals pain times resistance. Pain in this situation being can be any uncomfortable symptom. So that these vicious circles of avoidance are really what often characterize the disability that happens in functional disorders And what often makes them so challenging, because as providers, it seems like people are making themselves worse. And so we need to be able to intervene on that. Now, one of the first ways, again, is that part of the challenge is that patients have to have an explanatory framework that's compatible with their experience, right? I don't know, I mean, just in my clinic, how many times people have come in and they've been told, oh, there's nothing wrong with you, the tests are normal, everything's fine. But if you're sitting there and you're having constipation, you're having pain without a cause, or dyspepsia, or you're nauseous, when someone says there's nothing wrong with you, that's not reassuring. That just makes them mad. And if anything, they start to escalate to prove that there's something wrong. So as physicians, we can be extraordinarily reassured when we see a series of tests, a normal fecal calprotectin, a normal MRE, a normal ultrasound. But every test that comes back normal for a patient that has really distressing symptoms is just one more missed opportunity to figure out what's going on, right? So I think that's an important part of the stance. And that's oftentimes this gap in explanatory models is where we have so many difficulties with patients. So the kind of final essential that we'll be going into is really holding that effective management involves shifting patient and clinician attention from a primary focus on symptom control to functional capacity and engagement in valued activities, right? So that's where it's not like we don't want to control symptoms, but if we're only doing that, we're missing this huge part of behaviors, narratives, illness models that actually are driving a large part of the suffering, if not the dominant part of the suffering. Right now, that's a lot, and this I'm going to be going fast. So I'm also going to make some assumptions that I'm not going to touch on, right? So I'm assuming all of you are trainees or practicing in gastroenterology, that you can formulate a differential diagnosis for clinical presentations that includes appropriate next steps, including red flag symptoms. So I'm going to kind of just take that as a given. If I had more time, we'd go into that. I think that's not where I'm going to go today. Similarly, there are FDA-approved medications for IBS and other functional GI disorders, and I'm not going to be touching on those. I may talk about a couple medications, mirtazapine and propranolol, that can be enormously effective when used off-label. And I'm gonna blow through a little bit of visceral neurobiology, but that you can continue to self-study visceral neurobiology, but you'll get a taste of why I think it's important to know that and be able to articulate that to patients. Right. So I think the first thing when someone comes in our office with any DGBI, and I sometimes may use IBS as a sort of canonical case, but I think we're talking about the whole category of things that we might think of as functional, is we have to first have a framework to interact with the patient so that we have some alliance, right? And this is the first challenge that we have, right? This is a little cartoon of Rene Descartes. I think, therefore I am, the French philosopher. And he's often associated also with this idea of Cartesian dualism, the mind-body split. There's a soma, there's something organic, and then there's a mind that interacts. In his model, it was the pineal gland, how the mind and body interacted, but they're two fundamentally different things. And although this notion we think of, we've crossed over that with modern neuroscience, we really haven't, because we still use this language. It certainly was big in my training. We talk about an organic disorder or a psychogenic disorder, right? And I think what's challenging is oftentimes, whether explicitly or implicit, we tend to think of something that's functional as being psychogenic, right? And there are reasons for that. They're often very much infected by stress. Oftentimes there is an emotional component. But the problem is, once we are relating to a patient in this model, it puts them in what we call a double bind, right? Because that often gets translated into, if something's organic, it's real. And if it's not organic or it's functional, it's in your head, right? So then this double bind is that for the patient, if it's organic, and there's two unworkable solutions. Well, if it's organic and it's real, then it's not my fault. And so it's you, the doctor, it's your job to fix this, or my child, right? So then patients are coming in with this model. If I have a broken bone and I don't have anything to do with it, I may have broken the bone, but it's your job to fix it. It's your job to cure this disorder, right? On the other, which is not going to work for these disorders. On the other hand, if we're taking the other side of the split and it's psychological, then they're saying what you're saying, it's in my head. I'm doing this to myself. It's my fault. So then they feel blamed. And then there's the experience, well, there's nothing more that doctors can do. And unfortunately, sometimes physicians take this approach and they say, look, I've looked at the tests, there's nothing wrong. Go see your psychiatrist, right? So you can see inside of that double bind, there's just going to be no effective treatment. There's going to be no effective stance, right? So one of the first metaphors, I use a lot of metaphors in working. And this is a classic metaphor of sort of the fire department versus the electrician. And so I often use this a lot in my clinic early on, right? So if somebody comes in, what part of this in this sort of this dualistic model, patients have this idea of pain is sort of somatic pain. You know, if you poke your finger with a needle here, right, it hurts where the tissue damage is, and then it goes straight to your brain. We know that doesn't work for visceral pain, right? The pain does not often localize to where the issue is, and the intensity of the pain does not oftentimes localize or quantify how much tissue damage there is. So inside of that first model, it's like we think of pain as like a fire alarm, right? You're in a building, fire alarm goes off, the 4th floor, southeast corner, the fire department comes, they go up, they look right where the fire alarm says the pain's going on, no fire. Okay, everyone's out of the building, creates a problem, everyone goes back to work. Next day, fire alarm goes off, everything stops, work stops, fire department goes back. They look again for where the fire is. They don't see a fire, right? So, and that's kind of what happens with people with functional disorders. They're getting imaging, we check the imaging, everything's normal, right? So we kind of get intuitively, it would be sort of insane if the fire department, if somebody said to the fire department, look, the fire alarm is going off, so there must be a fire on the 4th floor. And that's, I think, what is often hard for us as clinicians, because that's kind of what patients are saying. Like, I hurt here, or I have a symptom here. There must be a problem right where I have pain. You need to find it. On the other hand, we kind of get, it would sort of be insane if the fire department said to the people in the building, hey, look, we checked. There's no fire. You're not really hearing an alarm. Just go about your business. There's no problem here. And that's oftentimes what people with these like screaming symptoms are hearing, right? So a metaphor that's useful, as I say, at some point, it's not arguing about whether the alarm is going off or whether there's a fire. There's an alarm going off and it's distressing and it's a problem. But instead of calling the fire department, we need to call the electrician, because there's a short circuit somewhere in the system that is creating this noisy signal, right? So this metaphor actually breaks us out of, is the pain true or not true, into it's the product of a complex system whereby things can start to break down, right? So you're breaking that mind-body split, right? So just to mention, there is the Rome 4, the whole Rome Foundation has started to define with multiple iterations functional gastrointestinal disorders, right? And so there are criteria for these disorders. And as I'll mention a little bit later, oftentimes giving a diagnosis can be enormously useful. Rome also has a lot of educational materials, and I'm going to use some of their slides in this presentation. But really, against the mind-body split, like this is how we start to think about, this clinical presentation and quality of life, all these factors that actually feed into this. And so we have this thing against this sort of organic versus inorganic. How do we start to account for genetic, environmental factors, epigenetic factors, central factors, which include cognitive, emotional, autonomic, attentional, right? Fear conditioning, and then all the factors that imply gut physiology. All of this is at play. So we want to have a way of starting to communicate this to patients so that they understand what they're dealing with is the outcome of a complex system, rather than this either or, there's damage where my pain is, right? A couple of other metaphors that I tend to like to use, right? So again, we're trying to break open this mind-body split. I often will use the metaphor also of the phantom limb syndrome, right? So this is just a picture of a Civil War soldier, but they started to know a lot of with low impact, a lot of peripheral wounds where there's a lot of pain before an amputation, we can develop phantom limb syndrome. Now, I like this metaphor, not because people necessarily know anyone who had it, but if you kind of look on the internet, it's a thing. And what I like about giving this metaphor is I can say to somebody, look, we absolutely know it's medically incontrovertible that not only can you have pain in a location of the body where there's not tissue damage, you can have pain in a part of the body that doesn't even exist anymore, right? So we know that the brain can create a pain model even in the absence of ongoing signals, right? Or ongoing tissue damage, right? Look it up. And then I will often use, on the other hand, we know that there's individuals that under trance states, under hypnosis, right? The kind of like swami on the bed of nails type thing, that people can go through. I might say something, people have actually gone through general surgery under hypnotic trance, right? In fact, before general anesthesia, surgeons were rated by their skill on two things. Number one, how quickly could they do an amputation? And number two, how good they were at hypnosis, because that's what anesthesia was in the early 19th century before ether and nitrous. So again, this metaphor can be helpful for breaking up this notion that it's not just a billiard ball notion of like tissue damage pain, but that the brain has a lot to say about it. And what's also good about those metaphors is it breaks out of this psychogenic notion that if you're having pain, it's because you're doing it to yourself or it's emotional, right? So I think that kind of stance is the first step, right? That's also why I would say, oh, sorry. So a few action steps right off the bat. So again, we want to come in, start validating a patient distress, right? But at the same time, we want to gently challenge any simplistic explanatory models that fall into this mind-body dualism, right? Because until you do that, then recommendations for behavioral or psychosocial interventions are going to fall flat. Metaphors, again, very, very useful for shifting the frame from mind-body dualism to integrated complexity, right? The fireman metaphor, the electrician kind of phantom limb. And then again, offering a specific diagnosis, like using Rome 4 diagnoses. So many times people come in and they're like, well, we don't know what your pain is about. It seems to be kind of, there's these maybe it's like IBS. And I find that just giving a specific diagnosis, oh, we call this is IBS mixed type. This is postprandial distress syndrome. It helps people feel like, oh, I'm being taken seriously. There's a name for this. And I think there's many times people come in with what we just call it functional, but we never go the next step and actually give them the specific diagnosis for which they do exist in Rome 4. It can be enormously reassuring and actually alliance building. Okay, and again, be careful of diagnosis of exclusion, right? It's important you're going to do things like rule out celiac, get fecal calprotectins, look at labs, but don't wait to start breaking the mind-body dualism until after you've done all the tests, right? Because again, every time you do a test, it is reinforcing we're looking for an organic cause, and it can kind of fuel that. So as you're doing tests, you're doing it in parallel. You're using your good differential diagnosis, and if it's feeling like a disordered brain-gut interaction from the outset, counsel with that in mind as you're doing the tests, not after, because at that point, people will feel abandoned. Okay, so once you've got this notion of like breaking the mind-body dualism, we want to start to do a little bit of psychoeducation about, well, okay, now how do I explain this, right? And in my experience, oftentimes psychoeducation is really helpful, and the physiology, even if people can't get it all, it helps them get the complexity. Now, I'm going to go really, really fast through this next bit, okay? But I'm going to invite everyone not to listen like trainees that are listening to a little section on GI physiology, but listening like patients who have this billiard ball model of how pain works. And now they're starting to hear, oh, I didn't realize it was that complex. Okay. So again, you can go in review the slides. So the point about this is like, the psychoeducation, we want to give people the sense of like, this is a really complex system, right? So I often just start about talking about the microenvironment. What are all the things that affect what's going on in the gut? It's not just injury, right? It's genetics, the neuroendocrine system, right? The enterochromaffin cells, neuroplasticity, microbiome, bile acid metabolism, food intolerances, immune activation in the gut, gut permeability, and then the brain-gut axis, including autonomic, endocrine, right? So you've got all these things that are affecting what's happening in the gut. And in fact, right, so you have, and it's not just a single, even the simplicity of the somatic dorsal root ganglion cell, in the gut, we have multiple afferents that are going up to multiple regions in the brain. And so there's at least 4 kinds of visceral sensation, right? We have vagal mechanoreceptors that are low threshold. We have spinal afferents, low threshold, that kind of feels like the gurgles. High threshold, those are activated in something like a blockage or an obstruction. And then silent mechanoreceptors, which actually don't transduce signal unless there's some degree of injury or inflammation, right? These are really important because this often explains why we end up with a post-infectious symptoms, right? It's because if you have microinflammation, these nerves actually now can be transducing signals where they wouldn't normally, right? And then so again, we have we have sort of peripheral and central factors, and there's going to be a spectrum for both people. Oftentimes you can have almost pure IBS that may be largely, if not entirely, peripheral, where we can have kind of chronic, kind of hypersensitive to pain that almost is like mostly central, almost in a sense like the model of the phantom limb, where now the pain is almost all centrally located. A couple other things, right? So we actually know that individuals that have disorders of brain-gut interaction oftentimes both have, you can see this in what this is basically showing is that the difference is that for individuals that have, they're under a colorectal distension model, IBS versus normal, they both have more signaling in the somatosensory cortex, right? So there's more higher levels of afferent input. And for a given level of afferent input, there's more activation in the central midline structures that underlie affect, right? So there's often this combination of there's more sensation coming from below, but there's more attention coming down from above. Okay? So again, we have this notion that there's also filtering systems, right? That, and again, I'm going very, very fast here. So just get the gestalt that there's oftentimes all this microenvironment that's sending more signals from above. Our brain at subcortical levels have filtering mechanisms that basically filter out extraneous, the kind of borborygmi and the kind of the constant sensation that's going on. Individuals with functional gastrointestinal disorders, oftentimes more of that background static that's filtered out is conscious awareness. So there's an impaired descending modulatory system, right? They often tend to have more affective responses. So there's more emotion based on that filtering. And there's cognitive, there often could be a cognitive component, right? About catastrophic narratives. So it's not that psychological factors aren't involved, but you can see that this is happening at multiple levels and they're all feeding on each other, right? Another way of thinking about this in IBS, right? So that there's more increased activity in ascending afferents coming up. So all those peripheral factors send more signals from the viscera to the brain, right? There's altered descending modulation. So more of that increased sensation is actually getting through that first level of filters. And then once it gets to that filter, patients with IBS oftentimes have more arousal, anxiety, and vigilance for that very same, right? So they're paying more attention and they're more worried about signals that are already increased to begin with. All right, so I just whipped right through that, right? But I might spend the better part of a session going and taking a deep dive, right? Because what the idea here is, it's almost like shock and awe. It's that relaying the complexity of this gastroneurophysiology, right, which I did very quickly just to give you a flavor, it starts to provide patients a conceptual framework that's compatible for their experience, right? If it hurts here and I'm worried about it, saying there's nothing wrong is not compatible with your experience. If it hurts here and I've just explained there's about 5 or 6 or 10 different peripheral factors, and there's 4 different kinds of nerves, and there's filtering in the brain, and then there's attention, now it can start to make sense. Now, as a patient, I can buy that maybe the pain here doesn't mean we have to focus on another test, that there is a complexity. It starts to build out that short circuit in the fireman versus electrician metaphor, right? I also notice I tend to start from the bottom up. I tend to start with peripheral factors, dysbiosis, food, sensitization of the afferents, right? Because if you start bottom up, it's going to be a little bit, it's going to validate the somatic approach rather than going right to central factors, attention and anxiety, where people might say, you're just telling me it's in my, that's just another way of you telling me it's in my head, right? So starting from the bottom up is, I think, a nice way of going. Okay, now that we have that, we do have to start to address this impact of stress and anxiety, because we see it, right? It's not like saying it's not psychosomatic is not the same thing as saying that stress doesn't have a huge role. Oh, sorry. So again, even if patients can't remember the details of all this, which they certainly can't, right? And this is hopefully what you got a taste of. Just the experience of having a physician spend 10, 15, 20 minutes just describing GI physiology starts to break down this notion of like, oh, okay, I get it. You are taking this seriously. This isn't just hand waving, right? So it's one thing to validate the suffering, but when you can actually provide some physiology behind it at every level of the system, from gut mucosa to brain, it tends to be enormously validating, reinforces earlier metaphors. Okay, but we do need to address stress, right? Because we see how much stress focus it shows up in these conditions. So one of the things I think is really, I like to make the point of, is stress is not just in your head, right? So when we think of anything that's a stress response, not just anxiety, but it can be anxiety, but anything that's stressful, the whole hypothalamic pituitary adrenal axis is basically, the head of that is corticotropin releasing factor, right? So, but it's not just a releasing factor for ACTH and then cortisol. Corticotropin releasing factor in and of itself is a stress modulator, right? So centrally, it can impact the experience of anxiety, depression in animal models, a lot of behavioral aspects of stress. In the gut, there is abundant corticotropin releasing factor receptors on mast cells, and I believe in enterochromaffin cells too, right? So literally CRF in the gut can increase motility, increase transit, it can increase secretion. Mast cell degranulation increases permeability. And it can actually increase irritability of nerves, right? So we actually see that stress is not just in your head, right? And in fact, when we look at patients that have IBS and we look at electromicrographs, right? So they may look normal histologically under a gross H&E stain. Under electron micrographs, what this is basically saying is that compared to healthy controls, IBS patients have more mucosal mast cells, more degranulating mast cells, more histamine release, and more mast cells that are in close proximity to nerve endings, right? Also, right, biopsy supernatants of individuals with IBS, if you take mucosa from IBS patient, you culture it, you get the supernatant, it actually leads to more irritability of mesenteric nerve preparations in vitro, right? So we start to see that there is a microenvironment of inflammation that increases nerve irritability. And what's the link? That stress actually can directly impact that physiology. So again, now that we've built this out, we can start to talk to our patients about managing stress, not as you need to relax, right? Your symptoms are just because you're too stressed out, but because stress leads to all these factors peripherally that make symptoms worse. How you feel pain, how your gut lining is functioning, right? How the muscles in your gut are contracting. So now, building this up, we've now created a model where people can accept stress management as being a medical intervention that's directly impacting the physiology of disorders of gut-brain interaction, rather than this black box of mind-body, you're too stressed, this is just your anxiety showing up in your gut. So again, when we start to emphasize the physiology of stress, it avoids the pitfalls of mind-body dualism, and it enhances the acceptance of behavioral and psychological therapies later on as a part of the medical management of disorders of gut-brain interaction. Okay. So I hope this is tracking. I know I'm going really, really fast. So, but there's a lot here. So now that we've done all this, and now that we've got an alliance, we've got a model working with our patients that this is a medical issue. We're giving it a diagnosis. It involves interactions between multiple levels. Now, how do we start to deal with behavior, right? Now, again, we're addressing avoidance a little bit later in the process now, because hopefully if you start to talk about what I'm just talking about right out of the gate, inside of mind-body dualism, doesn't work, feels invalidating. So I think the first distinction that's so important, I alluded to this earlier, is that we need to distinguish pain versus suffering. Because once we do this, we start to double our paths to intervention. Right? So we can think about pain in the broadest sense, and particularly in the GI world. Pain can include nausea, it can include premature satiety, it can include vomiting, it can, bloating, just any noxious or aversive sensation in the soma, right? And it's a natural consequence of being an organism with a central nervous system living in an environment not organized around our desire for pleasure, right? I mean, to be a living creature is to have pain, and that's a survival benefit, right? We know that families that have genetic disorders that don't allow them to perceive pain tend not to do very well, right? We tend to keeps us safe in many regards. Unfortunately, when the pain is internal, those same avoidance mechanisms that keep us safe from external threat end up increasing our suffering internally, right? And we can call suffering as the emotional anguish that tends to arise in the presence of pain. And it's often a consequence of having a mind, right? There's the suffering of like, I can't do this. How do I get out of this? What's wrong with me? All the ruminations, I can't go out, I can't be social. And in fact, again, just as a kind of interesting neural correlate between pain and suffering, there's a really cool study, I know it's almost 25 years ago, where they used hypnotic suggestion to define how pain was processed. And I think this is a really cool study, but essentially on the left, it wasn't a study of hypnosis, right? All the patients in this study, or all the subjects in this study, were highly inducible in hypnosis, right? So on the left-hand side, you see that like when individuals put their hands on a uncomfortably, like a noxiously hot plate, you get activation of the somatosensory cortex that basically kind of track to the sensory homunculus of the hand. And again, those midline structures that are responsible for affect, unpleasantness. After the hypnotic induction, the subjective report is that individuals noticed that there was a reduction in suffering or affective unpleasantness, even though perceptually this intensity of the stimulus didn't change. And that subjective report matched what they saw in functional MRI, which was the somatosensory cortex had the same level of activity, but the midline structure responsible for affect went down, right? So we do have a neural correlate for this separation between the intensity of a sensation and how much that sensation is bothering us. Now, but naturally, being creatures, like pretty much to have a nervous system is to try to move away from things that are uncomfortable. This is not just mammals or even vertebrates. I mean, I remember even in like high school, you don't even need a nervous system, right? I remember even in like high school biology, we got some paramecium and put them under a slide and put a little acetic acid, and you just watch the things go down their chemotactic gradients. So since the dawn of life, since the dawn of any kind of locomotion, organisms find a way to move away from things that are uncomfortable or distressing, right? The problem is what we see is, particularly in disorders of gut-brain interaction, what is uncomfortable is already traveling with you, right? And so what we see then is there's these unworkable attempts to manage these unwanted sensations, emotions, or circumstances, right? And what's problematic is sometimes these avoidance behaviors are effective in the short term, but they have a long-term consequence. And this is where I use another metaphor. And I literally, in my office, buy these woven Chinese finger traps in bulk, because they're a great model of how the mind actually works when we're in distress, right? If that in this metaphor, and by the way, it's handy to have these in your office. If you have this cardboard tube and you put your fingers in it and you don't want it, and this, in the metaphor, this represents anything you don't want, and you pull. Well, you pull because you want to be out of it, but then it grips you tighter. But as it grips you tighter, now you really feel the discomfort of the squeeze. And now I really want to be out of this. So I pull even harder. And now it grips me even tighter. And before I know it, what's bothering me even more than just the sensation of having this tube on my finger is the struggle. How do I get out of this? The focus on getting out of this to the exclusion of everything else, right? Very classic. And we see this so much in disorders of gut-brain interaction, right? I kind of put IBS with agoraphobia in quotes, but I think this is actually a real thing. Like, and so in psychiatry, panic disorder is not defined by the presence of panic attacks. It's defined by the anticipation of panic attacks and maladaptive compensatory attempts to avoid having panic attacks, like not driving, not going across bridges, not leaving the house. So we can actually see somebody has agoraphobia and they won't even leave their house to go get the mail. They might not be having panic attacks, but they're unbelievably distressed. And in the same way, we can often see this with individuals that have disorders of gut-brain interaction. They won't go to a restaurant. They won't eat in public. They won't go anywhere where there's not a toilet. And what you start to see, it's not the symptom. It's the anticipation of the symptom. It's the fear of the symptom. It's everything that they're not doing along the way, right? We often see inactivity and deconditioning. If there's any sense that the symptoms are provoked by movement, now they're not moving. Now they're becoming deconditioned. People using distraction to the exclusion of valued activities. Extended toilet sitting. This is a big one, especially in pediatrics. I always ask anyone who's got like IBS, particularly IBS with constipation, how much time are you actually sitting on the toilet, right? And you can see that sensation of incomplete defecation can lead people to keep sitting on the toilet, just trying to get empty. And then what happens? Now they're just reinforcing the brain-gut interaction, social withdrawal, rumination, food restriction, right? ARFID is a classic example of like, it hurts when I eat, so I'm not going to eat. Now, the problem is what we attend to, we amplify, and avoidance is an aspect of attention, right? We can't track if we're getting rid of a symptom unless we're paying attention to it. And I often use this metaphor of the cocktail party effect because, if we think about it, if we stand in a big room and there's 10 different conversations going on, we can eavesdrop on any one of those 10 conversations without moving our head, simply by moving our attention. But our nervous system can't process more than one conversation at a time. So auditorily, yes, we get all the sensation we need getting to our inner ear, but our higher level cognition, we can only parse out meaning. And so in the same way, our experience of that room is a function of where our attention is. Oftentimes, not the conversations in the room. The experience of somebody with a disorder of gut-brain interaction is not necessarily just a function of the symptoms, but the degree to which their attention is on the symptoms versus other aspects of life that matter, right? A metaphor that I often use also is, or it's just an exercise. I will often, you can do this along with me right now. You can see this very quickly, right? Just everyone who's just sitting there, just check in. What are you feeling in your right index finger? Just make note of that. Now, just take a moment to stare at your right index finger and really notice every single sensation, every pulse, every tingle, any sense of temperature, kind of focusing in all your attention, sensation, visual. You may even start to notice, you can even see the slight blush of the pulse. You may start to feel your pulse under your nail bed. Now, I see Lisa smiling. I'm presuming, Lisa, you're feeling more sensation in your index finger than you did just 30 seconds ago, yes?
Yes, it's very warm and tingly.
Right. Now that was 30 seconds. Now, by the way, I've been doing this for 10 years. My finger is on fire right now because I've done this so many times. I have reinforced a brain-finger connection. So every time I do this exercise clinically or in a talk, what predictably is going to happen is my fingers will be tingling for the next five minutes, right? But this is what we're doing. This is what our patients are doing if they're sitting on a toilet, right, for 5 hours. Now, if you have that much increased sensation in 30 seconds, this isn't psychosomatic, just as a function of attention, what happens if you already have visceral hypersensitivity and now you're doing this every day for hours at a time? You think that's going to make a difference on your sensation? Absolutely. Right? So this, particularly with whether it's toilet sitting or any other behavior that is trying to be avoidant, I often will use this to create the example of like, what we don't want to do is you already have a brain gut connection that's hyperactive. Attention will only drive that. So we don't want to just go to distraction. We want to actually learn to put our attention somewhere else, right? So this is that vicious circle that pain naturally leads to arousal. It naturally has us be hypervigilant and track where the pain is, but that needs to be broken. This is natural. We tend to track pain because pain signals threat, right? So that addressing that vicious circle, now inside of all those metaphors we did before, inside of brain-gut interaction, now you can ally with the patient and you're not doing it to yourself. This is how the brain operates. We track threat. It's normal, but we need to learn how to reprogram it. This is how we're starting to rework the short circuit, right? Again, a classic example of pain, excessive toiling, leading to increased visceral awareness, right? This also shows up, right, in conditioned responses, right? I like this kind of, this, Ivan Pavlov got the Nobel Prize, I think it was 1904, for his work on dogs, right? But one of the classic conditioning that we often see, and this can often provoke cases of ARFID, for example, is a Sauce-Bernays syndrome, right? Where noxious visceral sensations can lead to particularly powerful conditioned responses. If you haven't heard about the Sauce-Bernays syndrome, I can't remember I think there was a reporter who coined this, but the idea is, say you go out to dinner and you have a really fragrant, this rich, herbaceous kind of hollandaise sauce, delicious, perfectly prepared, but you happen to eat it when you're in the incubation period for norovirus. So 3 a.m., the sluices open up at both ends. What is predictable for most human beings is that you're never going to be able to eat sauce béarnaise again in your life. The thought of it, the smell of it is going to make you nauseous, even if you know it wasn't food poisoning, even if you intellectually know that it's the case that like you got infected. That mechanism in mammals in particular, one learning trial can create long-term conditioning, right? We see this a lot also in patients that have gone through very metagenic chemotherapy, where they will not be able to walk on the street in front of the infusion center without becoming nauseous or actually having a violent vomiting response. Another important part. So when you have people that have chronic nausea, it's really important to understand that the conditioned response to nausea can provoke the nausea. It's not psychosomatic. They're not doing it to themselves. It's actually how we're wired as human beings. And you can get the evolutionary rationale for it. You eat something poisonous, you eat something rotten, evolution doesn't give you too many chances to not do that again. So this mechanism is particularly relevant for people that have emetophobia, ARFID, that they have chronic nausea, and they're engaging in avoidance. And you really have to work on, right? So that what happens is they're punished by eating, restricting, we call negative reinforcement. This is where this avoidant behavior can become a vicious circle, right? So these food items become associated with noxious reactions. And then the avoidance behavior leads to short-term relief, reinforcing more avoidance. And then the associations can generalize. By the way, I think I gave grand rounds maybe, I think it was almost 8 or 9 years ago. We saw someone in Lang Porter, and it was one of 2 cases of scurvy that I've seen in my medical career. And his story was that he had kind of classic abdominal pain as a child. So his mother would restrict a food item. He'd get a little bit better. Then the pain would come back. She'd restrict a food item, get a little bit better. This happened over 10 years to the point where he was in his early 20s, and he would eat nothing but ground beef, plain, and white bread. He had scurvy, he had vitamin A deficiency, he had zinc deficiency, right? It's hard to get scurvy, but that was an extreme example of where this vicious circle of short-term avoidance actually led to multiple nutrient deficiencies, right? So these vicious circles are understandable, right? Whether it's avoiding food, whether it's avoiding eating, whether it's trying to sit on the toilet, whether it's avoiding like going out socially. But they lead to further disability, and they all tend to lead to disengagement from valued activities, because all these avoidant mechanisms, and you can track them, they look many, many different ways. But the paradox is they're all bringing more attention back to the symptoms themselves. It's like tightening the finger traps. So once we get to this point in the conversation, even as we're working on, we may give a lot of agents to try to increase the symptoms, we need to also withdraw our own clinical attention so that symptom management is secondary, and that the primary focus becomes, right, how do we address re-engagement with valued life activities, right? Because the symptom may be the source of attention, but what we put our attention on, we amplify. So we only want to be dropping in on symptom control as much as we can to kind of explain a new intervention, right? But we don't want to keep reinforcing this notion that I can't give up these behaviors until the symptom goes away, because that vicious circle isn't going to break that way. So when we talk about acceptance, right, it's not be with it. It's not you're stuck with it. It's not resignation. It's the willingness to have your experience because you're already having it, right? It's like to get out of a finger trap, you have to accept I've got this thing on my finger that will keep gripping me if I'm pulling on it. So it's not giving up. It's definitely not the MD saying there's nothing more we can do, right? It actually opens up the possibility of orienting behaviors around what matters. In other words, okay, this is what we've got. if you can be willing to have some of this, if you can be willing to feel a little fear, then can you start to expand the food items that you're eating again? If you can be willing to deal with a little bit of anxiety, could you be willing to start going out and re-engaging socially and getting back to school, right? If you can be with this sensation of incomplete evacuation, can you be willing to sort of proverbially poop or get off the pot and not keep, right? So its acceptance is not resignation, but it's actually the pathway to getting over suffering and actually improving your function. And then the paradox is, once you start to withdraw attention from symptoms, guess what? You let them be, but as attention goes other places, you now take some oxygen away from that vicious circle, and oftentimes the symptoms will start improving once you give up the need to. Please try again or press help. Okay, so again, there's the skillful action here. There's no silver bullet for functional disorders, right? They have to be addressed as an interaction of symptoms, right? But when we separate pain and suffering and they're distinguished as distinct, now we have new interventions, right? Avenues for intervention. And actually, oftentimes skillful counseling is largely sufficient. I mean, I went back, I've just had patients where just giving them the diagnosis, the family is crying because it's nobody told us this before. We thought we were crazy. It's like the diagnosis, we're like, well, we can live with the symptoms now that you've given me the diagnosis, right? So, you know, again, an example of what this would look like, I saw one woman several years ago, and she said, you know, she was having symptoms basically 3 days out of a month. And she said, what if I have this for the rest of my life? She was tearful. And I said to her, yeah, what if you had this for the rest of your life, but only 3 days the rest of your life? And for the other 27 days, you were no longer worrying about your symptoms. You were no longer be affected by it, so that you only truly had symptoms 3 days out of the rest of your life versus 3 days of symptoms and 27 days of worrying about when your next 3 days of symptoms were going to be. And it's kind of like she just sort of shook her head, and it was like, I could live with that. Like that's effective treatment. Even if the symptoms haven't changed, she just got back 27 days of her life, and then the symptoms are now a much smaller part of her awareness. Okay, so some other things to kind of build on this. I tend to think we should just always get in the habit of pairing a numeric pain ratings with subjective coping ratings, right? Because this actually prompts people, it reinforces this notion that you're dealing with something. There's a pain, and we can talk about how effective you're dealing with it. So just the question itself helps create that frame. I think it's always really important to get clear on those hidden meanings and fear that lie behind pain, because often in the explanatory model, there's something wrong, I have cancer, no one believes me, right? So oftentimes that explanatory model is hidden. That's why I started with it. That's why that's so important to get that right out upset, right? And again, looking all these different vicious circles, I think everyone should buy some Chinese finger traps. Unbelievably useful metaphor. Creating functional goals, we just talked about that. So work attendance, physical activity, normalizing sleep cycle, for sure managing toilet sitting time. And then again, linking goals explicitly to what matters, right? So it's not just get over it, but like, hey, let's get you back involved in your life as we're dealing with symptoms. Then people can be responsive to these referrals to psychological strategies, because you're not reinforcing, I think you're crazy, you're doing it to yourself. It's like, this is a way of managing all that physiology that we have already talked about, right? Okay, so I will stop there and take some questions.
Thank you, Dr. Sipe. That was such an incredibly powerful talk and helping us to switch our framework in thinking about